Shay Lunt. She is a senior consultant for Haugen Consulting Group. She has a Bachelor of Science degree in Health Information Management and a Master's in Health Services Administration. In addition, she is an RHIA. She's a certified professional coder. She's a certified professional medical auditor and a project management professional. So Shay really loves and works on the prophy side of coding. She enjoys doing lots of audits, lots of education and compliance. She works both with codings as well as physicians. So today's topic is going to be billing for a preventative visit and a sick visit. And Shay, I'm going to let you take it away.
All right, thank you very much, Kathy. Like she said, my name is Shay. I wanted to apologize right off the bat. I do have a little bit of a cold, so if you hear me sounding a little bit nasally, that's why. I don't normally sound this bad. So hopefully we'll be fine getting through the presentation today. So it is on billing for a preventive visit and a sick visit. This happens a lot. So if this is a topic you're struggling with, don't feel alone. Every time we do an audit, every time we're in front of physicians, this topic comes up. So it's kind of one of those age-old questions. It's one of those gray areas in coding. So today we're really going to focus on recognizing the difference between the sick visit and the preventive visit, and then identifying documentation needed. So this happens all the time. The patient's scheduled for a preventive visit and then mentions a separate complaint or maybe several complaints during that preventive medicine visit. And here there's just going to be times when it is appropriate to bill for both the preventive service and the problem-oriented service, but we really need that documentation to support the services that are billed. So a quick rundown, CPT definition of a preventive visit is a comprehensive age and gender appropriate history and exam. Includes counseling, anticipatory guidance, risk factor reduction, and then ordering of laboratory and diagnostic procedures. And this is going to be for an asymptomatic individual. So that's kind of a key part of this definition. Should be for an asymptomatic individual. So this is performed in the absence of patient complaints. So if you're thinking about back what I just said, when the patient starts bringing up complaints, that's when it gets outside of the definition of this preventive visit. So that's the CPT definition. CMS, when we're talking about the CPT preventive visits, they actually aren't going to cover those visits. So if you're billing CMS for preventive visits using the CPT codes, those are going to be non-covered service. What they do cover are called preventive wellness visits, and those are to develop or update a personalized prevention plan, and it's really to prevent disease and disability. So it's all based on the patient's current health and risk factors, and those visits are very well defined per CMS, and they have time periods in which they can be reported as well. So neither one of these visits are going to be time-based, so the billing won't be based on time. For the CMS visits, the spacing in between the visits is defined, and I'll go over that as well. So let's start with the preventive medicine visits, and these are in your CPT book as 99381 all the way through 99397. And they are based on the status of the patient, and that is the new versus established, and then the age. So you'll see different age brackets when you're looking at those patients, and it goes all the way from newborn up to the 65 and older. So just remember that these are going to be non-covered for Medicare patients. So the new versus established is going to be defined by the CPT definition, and that is going to be that 3-year rule that we apply to our E&M services, also applies to preventive medicine services as well. So the question is, has the patient received any professional service from the provider that they're seeing or another provider in that same group within the same specialty within the last 3 years? So that same question we ask ourselves for E&M visits also is going to apply for these preventive medicine services. Just a reminder, when there's a nurse practitioner or a PA that's working with a physician, they are considered as working in that exact same specialty. and the exact same subspecialty as whoever that physician is that they are working with. So that's one question we do get about those nurse practitioners and PAs, since they aren't as defined as by specialty as some of our physicians are. So what's included in the preventive medicine visit? And we're still talking about that CPT preventive medicine. It's going to be the history and exam, and that's based on age and gender. So if you're thinking history and exam like your E&M services, it's not the same. So the E&M services, those history and exam requirements are very detailed, and we're following documentation guidelines from our 97 and 95 guidelines. This is not the same. The preventive medicine definition is just that it's comprehensive and it's based on age and gender. So it's really up to the provider. There's some professional societies like the AAFP, and there's the U.S. Preventative Task Force that also puts out guidelines that a lot of physicians follow. So you might see those referenced. And then counseling, anticipatory guidance, risk factor reduction interventions, that's included. Ordering of laboratory and diagnostic procedures, so anything that's deemed to be needed based on this preventive medicine visit. And then that last one is insignificant problems or abnormalities encountered during the preventive medicine visit. So this is where our questions come into play. And the questions are always what's insignificant versus significant, and what can be counted to be outside of that and not included in the preventive medicine visit. So just keep that in mind as we go here. This is really the definition that we have to go by. So this is where it gets in that gray area of coding. So separately reportable are going to be immunizations, those ancillary studies, so the labs, the radiology, or any other procedures that are done, immunization administration, vaccine risk benefit counseling, and then that last one, significant separately identifiable E&M service. So that goes hand in hand with that last bullet we just talked about on the previous slide. But really, this is where it gets confusing. What is a significant separately identifiable E&M service? So that's what we're going to try to cover today. So this brings us right into polling question number 1.
Okay, Shay, I'm going to launch the poll. So everyone, you should see on your screen now our first poll. So what do you think? If a patient was last seen 2 years ago and now presents for her first annual preventive medicine exam, is this patient a new patient, an established patient, or you are unsure? So what do you think? If a patient was last seen 2 years ago and now presents for her first annual preventive medicine exam, is this a new patient, an established patient, or you are unsure? Oh, great. We've got a majority of you who have already voted. We're going to have some great discussion, Shay. So anyone else want to weigh in? That's the cue. You know, we're going to have some good discussion, so not everybody is saying the same thing. So I am going to close the poll. So last chance to put your voice in. I'm going to close the poll. 3, 2, 1. Okay, Shay, we've got 20% of our audience is saying this patient should be considered a new patient, and we have the majority is saying 80% it should be an established patient.
Awesome. So the majority of you are correct. This would be an established patient. So just going by the CPD definition of new versus established, the 3-year cutoff, if it's the same physician or provider seeing the patient, or a provider within the same group, same specialty or subspecialty, it has to be more than 3 years to bill them as a new patient again. So established is correct. Great job, guys. Okay, we are moving right into the Medicare preventive wellness visit. So I did want to go over these quickly since we covered the CPT ones. These 3 codes shown on the slide. So G0402, G0438, and G0439 are our Medicare preventive wellness visits. So if you remember back to the definitions that we went over, the Medicare wellness visits, these are those. The G0402 is the initial preventive physical examination, and that's called IPPE or Welcome to Medicare visit a lot. And then we have the initial annual wellness visit, the G0438, and the subsequent annual wellness visit, the G0439. So we've had G0438 and G0439 for a long time. G0402 is the newer one, although it has been around for a few years now. And these are the ones that have the specific requirements about when they can be reported. So for the initial IPPE, that's for a new beneficiary during the first 12 months of their Medicare Part B enrollment. The initial annual wellness visit is 12 months after that IPPE, or if the patient never got that IPPE within the first 12 months of their Medicare Part B enrollment, then you can report the G0438. And then the G0439 for subsequent annual wellness, that one you can report annually, but not within 12 months of an initial annual wellness visit. So those can get a little tricky on the guidance there for when you can bill what. So it's important to understand those definitions if you are billing these services. And it is a common question we get a lot. You can check with your MAC if you're not sure when your patient has, if they were seen by another provider, or if they're transferring care or something like that. It's tricky to know what has been billed and what hasn't been billed. Your MAC or your Medicare administrative contractor will have that information. So let's just look at some of the things required in these visits. So like I said, this is different than the CPT preventive medicine services in that it is very well defined as what needs to be happening and documented during these visits. So IPPE is the first column there, and you can see X's under what's required. So for the IPPE, we need medical and social history. We need potential risk factors for depression and other mood disorders, functional ability and level of safety. Then we go on to an exam. The exam that's defined in this is very, very simple. It's mostly going to be like height, weight, blood pressure, BMI. It's very simple. There's a lot of providers that will choose to do a more extensive exam, but that's, up to them. End of life planning, and then there's an education and counseling session that's going to include, other preventive medicine services. And when we get into the annual wellness visit, it'll also include a written screening schedule, a list of risk factors, and then a personalized health advice. So you can see what's required there for the initial, and the subsequent entails a lot of updating of that information. So all of this information can be found on the CMS website, and they have a lot of materials out there about these preventive wellness requirements. So again, if you're billing for these services, it's a really good idea to become familiar with these requirements, because they do specifically say if you don't meet all of them, then you're not supposed to bill the service. So one of the things I wanted to go into more detail about is that row on there that says administer health risk assessment. So what's a health risk assessment? And this really fits into the definition of that of the CMS wellness exam pretty well. So it's something that either the provider or the beneficiary completes. It takes no longer than 20 minutes. It can be collected either before or during the visit, and it should be tailored to the communication needs of the patient. So either a different language, or maybe there's a literacy barrier, should be tailored to that patient. And then at a minimum, it addresses demographic data, self-assessment of the health status, psychosocial risks, activities of daily living. And a good example of an HRA is on the CDC website. So I put that reference right there if you're looking for one to show your providers. So physical exam versus a wellness visit. So like I mentioned, Medicare is not going to cover what we consider an annual physical exam, which is that CPT preventive medicine service. So many people will consider a yearly trip to the doctor for a physical part of routine care. Some may think that a physical is like a head-to-toe assessment of health, and we would expect tests, screenings, x-rays, procedures. The National Institutes of Health describe a physical exam as studying the body to determine if there is or not a physical problem, and they define this by saying it includes looking at the body, so inspection, feeling the body with fingers or hands, and that's palpation, listening to the body sounds, so auscultation, producing sounds, usually by tapping on areas of the body, and that's percussion. So there's no mention here of specific tests or procedures. This is really just the provider gathering information through his or her senses. And I just want to be clear that Medicare does not cover an annual physical exam as what we just defined or as such. So it's kind of confusing, but the Medicare annual wellness visits are going to be important visits for those Medicare beneficiaries. And although they're not physical exam, in many ways they are accomplishing the same thing. If your provider is doing physical exams for Medicare wellness or Medicare patients, just know CMS doesn't require providers to submit claims for non-covered services that are provided for a patient at no charge. But the decision on whether to charge a patient for non-covered Medicare services is at the discretion of each provider. So what happens? The patient presents for an annual preventive medicine service and arrives in the exam room with a long list of concerns, questions, complaints. Some of these are pre-existing, some of them are new. The provider wants to discuss screening tests, healthy behaviors, and risk factor reductions, but the patient might have another agenda. So what can the provider do? So there's really three options. None of them are perfect. So the provider can do 2 services for the price of 1, and they can ask the patient to schedule another appointment, or we can bill both. So both the preventive service and the E&M problem-oriented service. So there's likely going to be work done for the problem-oriented service that would have been performed during the course of a routine preventive service. So in other words, there's going to be some overlap of work. So if any portion of the history exam was performed to satisfy the preventive service, that same portion of work should not be used to calculate the additional level of problem-oriented E&M service. So only the work that was performed above and beyond what would have been performed during the preventive service should be used to calculate that additional E&M oriented level service. So that's really where it gets tricky. So let's just go into each of these options. 2 for the price of 1. So you could report only the preventive visit. So some providers report only the preventive medicine service even when they address multiple or acute issues. I've seen this in audits. I've talked to providers about this as well. It might just be their preference or their clinic, how their clinic decided to handle this. Why? Medicare practices reports that many payers will not reimburse for the second service and that patients are expecting a free preventive service. Patients are also becoming dissatisfied when there's a copay or the charge goes towards their deductible. And then the last point I've heard is that state Medicaid programs will often only pay for 1 E&M service on a calendar date. So again, this is really, they are getting 2 services for the price of 1. And as far as practice management goes, this might not be what is preferred, but it is, happening and it is an option. The next option was to set up another appointment. So this could be, you report the problem-oriented visit, and this is probably for a patient that's more in like a medical crisis or really needs attention right away. You're going to do the problem-oriented service and then reschedule the preventive visit. So this would be telling the patient there isn't going to be time for both. Just know also here that if the patient's coming in for a preventive visit, they're probably expecting there to be no copay. So when you get into billing a sick visit, instead of the preventive, you're looking at a copay. And when you get into billing both, you're looking at a copay as well for that sick visit. So the next option for form and bill both, the patient's going to be charged for both the preventive and the problem-oriented visit. There's a lot of questions about this, like, do you need 2 notes or 1 note? The answer to that is that they don't have to be separate notes. They can all be within the same note, but you must be able to distinguish what is separate, separately identifiable from that preventive visit. The documentation has to be complete for both services. Diagnosis assignment is also a question, and then we have to append Modifier 25, and that will go on the problem-oriented visit. So some coders will recommend 2 notes, one for the preventive service and one for the problem-oriented service. This really isn't practical in a lot of situations. So it's really just going to be up to the provider to document the service clearly if they are going to use 1 note. For the problem-oriented service, you're going to be looking for key components, so history, exam, and medical decision-making. And then we're going to be looking for a diagnosis. So you'll have separate diagnoses for the preventive visit and for the sick visit. And then again, I mentioned that copay. So the copay is going to be, could be an issue, and you'll, if you work in a clinic, it'll probably need to be addressed, within policies and procedures on how to handle the copay if this comes up. So the guidelines pertaining to this, there are CPT guidelines, and the CPT guidelines are there, and it's quoted that they really say the problem should be significant enough to require additional work to perform the key components. And then you can use the E&M levels to report that service. CMS, so when we're talking about those G codes, the Medicare Wellness, they specifically say Medicare payment can be made for a significant, separate, identifiable, medically necessary E&M service. And then they go on to say it must be medically necessary to treat the beneficiary's illness. So I thought that was a good word to point out. They probably aren't just going to be talking about something. They really should be treating a problem, or just not just discussing it, but really treating a problem. So this brings us right into polling question number 2.
Okay, I'm launching the poll. So the question is, in order to support billing for both the preventative and the E&M visit, the provider must document 2 separate notes. Yes, no, or unsure. So in order to support billing for both the preventative and the E&M visit, the provider must document 2 separate notes. Is that true, false? Is that yes, no, or unsure? So anybody else want to weigh in? We're going to have a little discussion again, so don't be shy. Anybody else? 2 separate notes versus 1 note. What do you think? Okay, Shay, I'm going to close the poll. 3, 2, 1. Share the results. We've got the majority that are saying 83%. No, we do not need 2 separate notes, and we have a few people at 17% say they are unsure if we need 2 separate notes.
Okay, so great. You guys did great. You're correct. You do not, it's not required that you have 2 separate notes, although it is nice. It's definitely not required, and we know it's not practical a lot of times for physicians to document 2 separate notes when it is happening during the same encounter. So it's not required, but the documentation does need to support both services. So that's what we're going to talk about next. And we'll start with the history part. So this is this part of the presentation, we're really just talking about the documentation requirements for billing both the preventive service and that problem-oriented service at the same time. So that for the history part, the preventive service, remember, isn't a It's not problem-oriented. It doesn't involve a chief complaint or a history of present illness. For the problem-oriented service, the history documentation does involve E&M criteria. So we're going to need a chief complaint, a history of present illness, a review of systems, past family social history. That all needs to be documented to qualify for that problem-oriented E&M service. So there is a big difference between history documentation for preventive versus that problem-oriented service. And then when we move on to exam, the preventive medicine examination is based on age and gender. So if you're talking about the CPT definition of the preventive visit, it's going to be that comprehensive based on gender and risk factors identified. If you're talking about a wellness, Medicare wellness visit, that exam is going to be defined by CMS. So like I mentioned, it's a pretty quick exam. It's mostly going to be those vital signs, height, weight, blood pressure, BMI. And then for the problem-oriented service, the E&M exam criteria will be covered. So if the patient is, say, complaining of chest pain, the expectation would be for one of the systems examined to be cardiovascular or respiratory system. So the exam criteria is going to be applied, and you're going to count your exam elements and come up, with either an expanded problem, detailed, comprehensive exam, whatever the documentation supports. And then for medical decision making, for a preventive medicine visit, medical decision making is not in the criteria for the code. The preventive medicine visit is going to involve the counseling, anticipatory risk factor reduction, and any interventions that are going to be required. And then for the problem-oriented visit, we get into our tables for medical decision making. So like here we have table A. If your MAC follows the 3 tables, these are some of the common ones, but we'll have number of diagnoses and our management options. We have amount and or complexity of data reviewed, and then the last one is the risk. So for that problem-oriented service, the problem-oriented service will really be figured based on our E&M criteria for medical decision making. So here's some documentation tips. And these would be good to share with your providers if you're struggling through this. The documentation really needs to support both services. So if the documentation is created in one document to support 2 services, the provider must clearly delineate the problem-oriented history exam and decision-making from the preventive service. So one example, maybe a patient comes in with some new hip pain, and the provider does a thorough musculoskeletal and neuro exam of the left hip, and that directly relates to the HPI, which describes that hip pain. That's really going to be different and outside of the usual preventive medicine services. So that's one example there. The other option that we do run across quite a bit is to document the problem by time. So you would document the entire preventive service, document the problem, so that would include the HPI or in the rest of the additional history, the exam finding, the assessment and plan, and then we'd also need a time statement that includes the total time spent on that additional problem, the time spent in counseling for that problem, and then a summary of what was discussed during that additional issue time spent. So this isn't required, it's just an option, and it is useful for providers. So let's take a look at some examples. So this would be some documentation that maybe would appear after the documentation for the preventive service. So they actually titled it Significant Additional Issues, which I actually have seen that exact title in notes before. And they go on to list very clearly the E&M components. So they have the chief complaint, the history of present illness, the review of, the review of systems, the past family social history, and then they have the exam, and then they also have an assessment plan that very clearly is treating a problem here. So the asthma. So this could actually be coded out, and depending on your E&M components, exactly how you're counting them, it could be maybe like a level 3 visit, or maybe even a level 4 visit established patient. So this would be separate, separately identifiable from that preventive medicine service. And then here's that same patient coming in, and again, this is a significant additional issue. So we have chief complaint, HPI, exam, we have a plan, and then this provider adds a time example or a time statement. So he says, I spent 15 minutes total on this additional problem, 10 minutes of which was spent on asthma control, new medication compliance review, and putting a prevention plan in place. So this would also be considered to bill based on time, whatever E&M level. So 99213, whatever supports the 15 minutes total. So this brings us to polling question number 3.
Okay, here's the question. A preventative medicine visit should always have a chief complaint and an HPI. Is that true, false, or you don't know? So what do you think? A preventative medicine visit should always have a chief complaint and an HPI. And we've got responses trickling in. It's speeding up a little bit. I think we've got them thinking about this one, Shay. So take a couple seconds. What do you think? A preventative medicine visit should always have a chief complaint and an HPI. If anyone else wants to weigh in, I'm going to go ahead and I'm going to close the poll. 3, 2, 1. Shay, 100% of who answered this question says the answer is false.
Awesome. Great job. Yeah, the preventive medicine does not have that chief complaint or an HPI. And it's kind of confusing for providers, and in a lot of notes templates, you'll see that they have to fill out a chief complaint, even if it's a preventive medicine visit. And they can always just put, the patient's here for their annual preventive medicine visit, or if that is a Medicare patient, they could even put the patient's here for their IPPE or their annual wellness visit. So you guys are correct that chief complaint and HPI is just for the problem-oriented visits, not for the preventive medicine. Okay, so next we're going to talk about Modifier 25, and I mentioned this briefly that if you're going to bill both the preventive and the sick visit, you're going to need a Modifier 25. So the guidelines say, both the CPT and the CMS guidelines say, that only one E&M service code per patient, per physician, per day is eligible for reimbursement, but they do call out some exceptions. So, and one of the exceptions is the preventive medicine service. So they say the preventive medicine service may be reported with one problem-oriented E&M service, and that includes the wellness visits, the GO402, 0438, and 0439. The confusing or the tricky part is that the 25 modifier gets applied to the E&M service. And I don't know if that's necessarily intuitive to us. To me, when I think about it, sometimes I'm thinking, well, they came in for the the preventive service, so I want to apply the modifier to the preventive service, but it's actually the other way around. So the modifier gets applied only to that E&M service, and that just designates that it's a significant, separately identifiable E&M service by that same physician on the same day of service. So always remember your Modifier 25 goes on your sick visit. And I know that's confusing, and we see it a lot in audits as well, where Modifier 25 is maybe on the preventive service, or sometimes it's even applied to both services. So next topic is medical necessity. So it isn't simply a matter of the patient having a chronic underlying condition or a new problem, whatever they come in with. Really, all services that are billed to any insurance carrier must be medically necessary. And it's actually part of the attestation statement that's included in the physician's signature box on the 1500 claim form. So it really is important to understand medical necessity. So let's just go over a few examples. If the patient had been seen fairly recently for a follow-up for these same conditions, and he or she was stable at the time, and then nothing was found during the preventive medicine portion of that current visit that they're in, nothing indicated that any of the problems had worsened or weren't adequately controlled, then just because the patient has those chronic underlying conditions doesn't mean you're automatically going to report a separate E&M service when they come in for their preventive service. So in that situation, it sounded like they were doing regular follow-ups for that for those underlying chronic conditions. So when they get to those preventive medicine visits, they're really just focused on the preventive medicine part. In another example, a significant amount of time had passed since the patient's last formal assessment of those same conditions. However, the patient was due for a follow-up visit anyhow, and the patient and the doctor simply chose to conduct the medically necessary follow-up of those conditions at the same time as the preventive medicine service. That's fine. It could be something that the patient and the doctor agreed upon beforehand. And again, as long as the provider's documenting those problems and the preventive medicine services, that could support medical necessity. So if it was a medically necessary assessment of the chronic problems and not just a quick peek to make sure nothing had changed since the last assessment of those problems, the key is really just going to be that additional work. So it's the work performed over and above what you would normally do for a preventive medicine exam that can be counted towards an E&M level. So here's a few more examples. So in the bill both visits category, we have patient with a skin cancer history, and then they also have a skin lesion that has some growing borders. The doctor might do a more detailed exam, maybe order a biopsy, refer to a dermatologist. That's all going to be additional work, and that would support medically necessary services and being able to bill both of those visits. There's another patient who presents with worsening asthma symptoms and then requests a new prescription. And here's a question, and it would really be up to the provider again, but does this require testing, evaluation, and medication management? It likely does because the patient's asthma symptom is worsening, but it could also go the other way as well. Like in the other example here, we have well-controlled hypertension, normal blood pressure at the time of visit, been on the same medication for years, just needs a medication refill. So that would be a scenario that probably does not require additional workup. And that brings us into our next slide, insignificant problems. And this is an example in the CPT guidelines. We went over this early, but if it's insignificant or minor, it's going to be included in that preventive medicine. And actually one of the examples they give is refilling prescriptions for existing problems. And it's not considered significant additional work. So that example that we just went over would fall into that example pretty well. Okay, let's move on to ICD-10 coding. For your preventive medicine visit, these are kind of your options. ICD-10 breaks out the age of the patients in these encounters for preventive visits. So we have adults, and that can be without abnormal findings or with abnormal findings. And then we have newborn, and that's going to be under 8 days old or 8 to 28 days old. And then we have child, and that's going to be with or without abnormal findings as well. And any of the codes that say with abnormal findings, the ICD-10 book does instruct you to use an additional code to identify those abnormal findings. We also have some coding clinic advice on these codes as well. So these are some great examples, and I put the reference up there. So you'll, I know I'm using a version of the ICD-10 book that actually has the coding clinic references in them. So if you're using that same version, you might see these references, and I went ahead and summarized them here. He's a patient that's seen for a well exam, and then they also have otitis media, so that's when you're going to use the abnormal findings, preventive medicine, and then with that otitis media code. The next one, the child has viral bronchitis that was diagnosed previously, still under treatment. Since it's not a new finding, this was going to be the no without abnormal finding code, so Z00.129. And then the last one is going to be a patient asthma, and then he's actually being diagnosed with acute exacerbation. So that's going to be another abnormal findings code with the asthma. And then they also have some adult variations of this advice as well. So you can see here, the first one is going to be a patient that was diagnosed with hypertension, and the patient's blood pressure is actually elevated during the exam, and they end up adjusting medication. That's going to be an abnormal findings one with the hypertension code. And this is the next one is another adult. She has a diagnosis of COPD and is complaining of shortness of breath. So the provider does diagnose an exacerbation of the COPD. That's going to be another abnormal finding and diagnosis with the COPD diagnosis as well. And then the last one, the patient is presenting for her annual well exam, and she's a current smoker with COPD. So no new exacerbation, no new diagnosis. This is going to be without abnormal finding one, but we will go ahead and code the COPD and the current smoker status. So that bottom one, it's just really the point is that there's not a new problem or an exacerbation of a pre-existing condition. So just a quick reminder as well about diagnosis coding. When we're talking about professional services, for those office visits or E&M services, we're going to follow Section 4 of our ICD-10 CM guidelines. And I think Sections G and H are really helpful. They say to list the first ICD-10 CM code for the diagnosis, condition, problem, or other reason for the encounter or visit, and then any additional codes that describe coexisting conditions. And then we also have the rule that we can't code uncertain diagnoses documented as probable, suspected, questionable, so anything that's not sure. And instead, we'll have to code the signs and symptoms for those types of diagnoses. And this brings us right into, I think, our last polling question.
Yep, Shay, you are correct. It is our last polling question. So it's your last chance to give us your thoughts. So the question is, if billing a preventative visit and an E&M visit on the same date of service, each visit should be associated with a different diagnosis code. Is that true, false, or you don't know? So if billing a preventative visit and an E&M visit on the same date of service, each visit should be associated with a different diagnosis code. So what do you think? And I feel like everybody's wheels are turning because I'm just now getting some responses to come in, Shay. So what do you think about this question? Is it true, false, or you are unsure? Great. Now we've got some responses slowly trickling in. I think this is the toughest polling question yet, Shay, so it's probably good it's towards the end of the presentation. And I think we're going to have some good discussion. So anybody else want to weigh in on this? If you are billing a preventative visit and an E&M visit on the same date of service, each visit should be associated with a different diagnosis code, true or false? Okay. Oops, got a couple more people responding. I'm going to go ahead and close the poll. 3, 2, 1. Okay, Shay, we've got some discussion. We've got 60% of the audience is saying this is a true statement, but we've got about 40% that is saying it is false.
Okay. Yeah, so this is kind of a tricky question. They really probably should have their own diagnoses code, and that's really going to be to support the medical necessity of the visit. So your preventive medicine services is going to have a Z00 point whatever to support your preventive medicine service. So that's going to be the encounter for preventive medicine service. And then your E&M visit is really going to have whatever problem the patient came in for. So those of you who answered false, you know, I think that's okay too, because I know in some scenarios, you know, all diagnosis codes are going to get linked to each of the visits, which is probably fine as long as you're not seeing any denials. So this was kind of a trick question. I just kind of wanted to get a feel for how everyone felt about this. But if you do think about it logically, you should have some type of diagnosis code on there besides your Z00 code to support that additional E&M service. Okay, so just to kind of review everything we talked about when we are coding for both the sick visit and the preventive visit. You're going to code the preventive visit based on the type of visit, and you're going to have to follow either your CPT codes or your CMS if you're billing a Medicare wellness visit. And then you'll follow your E&M coding guidelines for the E&M. So the documentation has to stand on its own and then support the level of service based on the key components. So you're going to go over your history, your exam, your medical decision making, and count what type of E&M service can be supported, or if the provider is calling out that separate E&M service by time, you'll see what your time supports. And then I did have some examples to review. So patient presents for a well visit, and this patient is a 99393, and the significant, separately identifiable 99213 E&M service also takes place, and this is to address cellulitis. So this is just to show you coding. For the we have a little bit of a typo here, but for the 99393, for that preventive medicine service, we'll have the Z00.01, and then we'll have the cellulitis code. For the 99213, and we'll put the 25 modifier on that E&M service, we will link the cellulitis. So LO3.90, that cellulitis code, will go with our E&M service. The next example, the patient presents for a well visit, and this one's a 99394, and then they also address a right ankle sprain, and then they receive some vaccinations. So the vaccinations are coded separately, and then we're also going to code our E&M service. So this one looks kind of funny because we have a modifier 25 on both, and that's because of the immunization. So most payers are going to require that if you're also coding immunization to be able to be reimbursed for both. So for the ICD-10 codes, we have the Z00.121, and then we have the ankle sprain. The ankle sprain is going to be linked to your E&M code, and then for your immunizations, we have the encounter for immunization. And I do have a comment that says new ankle sprain wouldn't have a subsequent 7th character, and that is correct. That should be A. That 7th character should be A on there. So we will have the Z23 diagnosis code for the encounter for immunizations on those last two CPT codes. So philosophies can differ on this, and we've certainly seen this, and we've met with many providers. The same group practice might differ on this issue, and what we would just recommend is to make sure your providers are talking to your coding and your billing staff, and that there's even a written policy. That consistency is going to be what helps both the providers and the staff answer any patient questions that come up regarding this. And it's going to be help with consistency between provider to provider. And again, we've definitely seen this in action. Providers sit down and talk about it, and it really helps, to know when they are going to bill for both the separate and for the separate sick visit and preventive visit. Here are references, so we really just use CPT and ICD-10, and I mentioned Medicare as well. All right, thank you guys very much for joining me today. My contact information is on the slide, so be sure to contact me if you come up with any additional questions.
Great, thanks, Shay. Hey, we did have a couple questions come in, so we have a few minutes, so if anybody else has any questions, please type it in the chat window and we will ask Shay. But the first question, Shay, that came up was, what diagnosis code should be used to report an annual visit or an IPPE visit?
Okay, that's a good question because my examples were really focused on CPT, but we would still recommend using that Z00 series, so either with or without abnormal findings, and you'll be using the adult version of those codes, but there's not, CMS actually doesn't call out which code has to be, so they don't have a requirement for which code has to be applied with those annual wellness visits or IPPE visits, but the one that makes the most sense to us is that Z00 series.
Okay, thanks, Shay. Okay, and we've got another question. What is Modifier 33 used for?
Okay, and that is also a great question. So Modifier 33 was in response to the Patient Protection and Affordable Care Act, and that requires health plans to begin covering preventive services and immunizations without any cost sharing. So Modifier 33 was supposed to be able to, or was to identify insurers that the service that was provided was a preventive service. So it's really payer by payer basis. So some payers are going to require you to use Modifier 33 even on your preventive medicine services, which is kind of counterintuitive since you're thinking that the CPT code already defines it as a preventive service. But really, if you're seeing denials on your preventive services, that would definitely be something to check on and see if you have any contracts or anything like that that payers are requiring that Modifier 33 for. But again, it's really going to be payer by payer basis, and it is in response to the Affordable Care Act, and the intent is just to identify services in which the cost sharing for the patient does not apply.
Oh, great, Shay. Thank you for that. I don't see any more questions, so I want to thank everybody for your time and attention. I want to thank Shay for a wonderful presentation. I also want to encourage everybody, you will receive a follow-up email tomorrow or the next day. In that follow-up email will be the recording link and handouts again as well. And so you are able to forward that on to the rest of your team, and there will also be a test portion in there that your team will need to take if they did not listen in here on this live event. As soon as we close out, you will also receive a survey. Please let us know what you think about this and give us any topics that you are interested in the future, as we are planning now for our 2018 already. And we also need record of the survey and or tests just in case we ever get audited from AAPC or AHIMA. So again, thank you everybody, and go and have a great rest of your day, and hopefully we will see you next month. Thanks. Bye-bye.